Good afternoon. Thank you for joining us. I'd like to introduce you to Akari. We'll be following through a portion of her care journey today as we diagnose, treat, and then report on her case of melanoma, all the while showcasing many different interoperability solutions happening behind the scenes. So recently, Akari went to her primary care physician with concerns over an unusual mole on the top of her right shoulder. During that appointment, Akari's occupation was documented, and you can see that right here. She's a lifeguard at her local community swimming pool. This type of occupational information is important to collect as part of the clinical data set so that we can better identify emerging occupational as well as environmental health concerns. Additionally, this information is a proposed part of USCDI. So Cerner will provide this occupational information to the Washington State Cancer Registry via FHIR. We'll hear about how that data is used later on in the presentation. So Akari's PCP, Dr. Callahan, examines the mole with the knowledge that Akari does work outside during the summer months, and she suspects melanoma. So she refers Akari to a dermatology oncologist. The referral, which we're viewing here, is sent from Dr. Callahan to Dr. Hahn. We can see that the reason of referral is an atypical mole, and because of the structure of the report, it's really easy to flip between sections so we can quickly look at the problem list or review the documented problems that Akari has before we do a physical examination. So upon examination of Akari, Dr. Hahn decides that we're going to do an excision of the mole in office. Once that excision is done, we'll place an order within Cerner PowerChart, and we'll send this pathology tissue request to the outside lab, and UiPath will tell us a little bit how that pathology is then resulted back into Cerner.
Excellent. Thank you, Jennifer. So Dr. Terzo received the order from Dr. Hahn, and so begins the second part of Akari's journey. It's essentially the waiting part. So she was told by Dr. Hahn that there is up to a 7-day wait to receive results from the laboratory. As you can imagine, that's a significant amount of stress for Akari. One of the things that Dr. Terzo realized in this process is that she wanted to implement automation to reduce those cycle times. She implemented automation in a couple different ways. One in an association with pending labs, so robots essentially manage pending labs. For example, they reassign orders based on availability or capacity for pathologists dynamically within the lab information system. They also use AI components to essentially do reads on the slides and then also auto-create the reports within the lab information system to speed up the process for turning those orders around to the pathologist or to the referring physician. In Akari's case, there was a very specific robot that Dr. Terzo implemented, and that is a robot that essentially manages pending labs and a report called pending labs in resulted 24 hours. What the robot does is essentially it goes through the system and sees what labs are pending and what labs have recently been resulted regardless of the lab information system that you have. So once it finds that result, it's going to grab that report, it's going to package it up into a FHIR bundle, it's going to then send it to Cerner, and then also to the Washington State Cancer Registry, so that there's no human intervention in that process. So let's take a look at that robot today. So it's going to extract the file, and then it will kick off, and once it has identified that Akari is the patient, it's going to search for Akari within the system. And once it finds Akari, it's going to navigate to the document section associated with her file. It's going to then pull that pathology document out of the system. And once it has that pathology report, it's going to use intelligent OCR to extract all the data associated with it. Once it has the data, it's going to wrap that up in a FHIR bundle. And once we've created that FHIR bundle, as you'll see here in a second, it will then, so this is the document that was created from the FHIR bundle that we're going to then send to Cerner. And I'm going to click OK. And these pauses we put in here primarily for this demonstration. Typically this would happen in the background and no one would be the wiser. So we posted successfully to Cerner with that FHIR bundle. We're then going to create the FHIR bundle specifically for the Washington State Cancer Registry, which is the diagnostic report. So you can see that we've created that. And I'm going to click OK. And at this point, we're going to send to the Washington State Registry. We're going to get a successful posting, and I'm going to pass it to Maria.
Thanks, Melvin. So I'm Maria Spicchio from OptimizeRX, and I'm going to be demonstrating what happens when the pathology report makes its way over to Cerner's PowerChart and Dr. Hahn, and our technology, which is designed to support care delivery and save time for physicians by providing care planning resources directly within the clinical workflow. So here we see Dr. Hahn pick up in the patient chart of Akari and take a look at the pathology report that was just sent over by UiPath. And in so doing, he is able to go ahead and confirm her diagnosis. So he navigates over within her chart to the diagnosis and problems section. And as he adds her diagnosis, goes to add her diagnosis, this is the first time that we see the OptimizeRX technology at work. At the bottom of the screen here, you're seeing a message about a recently approved treatment for advanced melanoma. Dr. Hahn is receiving this information based on his NPI number, as our technology has identified him via AI and real-world data assets outside the EHR, such as the pathology report that he ordered, as well as Akari's results, as somebody who may be treating patients with advanced melanoma. And so at this point, if you'll remember, Akari has not yet been diagnosed, and so he is receiving information about potential treatments. If he's interested in understanding more about this treatment, he can click to read about the clinical trial results for this recently approved treatment. As he goes to search for melanoma to officially record her diagnosis, he selects the superficial spreading melanoma, which he did see in the pathology report. And as he adds that, you'll see that the therapy planning resources tab updates to an actively enrolling study. This is based on the ICD-10 code that he has just entered. And he can see that this is a study for patients at high risk of recurrence. And of course, he remembers that Akari is a lifeguard and therefore likely to have a high risk of recurrence. So he takes a look at the IE criteria, again, directly within workflow, and sees that in order to be eligible, she must be 10 weeks post-surgery. And so he closes out of this and makes a note in Akari's chart for office staff to follow up with her at 10 weeks post-surgery. So now Dr. Hahn has completed his diagnosis and is thinking about maintenance care. He's a bit concerned about the inflammation that he saw at the biopsy result, from the biopsy results. And so he searches for an anti-inflammatory medication to prescribe for Akari that he can discuss with her upon follow-up. And here you'll see, again, the optimized RX technology at work with the coupon indicator that's showing up right aligned with the treatment. And the idea here, again, is to stay one step ahead of the care plan for Dr. Hahn and to provide him actionable information right within workflow that he can use to discuss during Akari's treatment conversation. And so here he can see that there are affordability resources available for Akari. He can discuss those with her and also give her immediately actionable information as well, in that she can text 55150 to go through a short conversational SMS enrollment and receive a mobile copay card directly to her phone so that her pickup at the pharmacy is seamless and easy. This number is a live number and can be texted at any time to demonstrate that technology as well. And now we're going to move over to MedMorph to talk about how the EHR results go into the cancer registry. Thank you.
This is Maria Michaels with the CDC, presenting on making EHR data more available for research in public health, or MedMorph, and specifically focusing on the Backend Services app, or BSA. So, in addition to taking care of Akari clinically, data needs to be submitted to state cancer registries for cancer case reporting, and indirectly to the Washington State Department of Health for inclusion in a clinical research study being done jointly with the University of Washington Fred Hutchinson Cancer Center. MedMorph extracts data from the EHR, repackages it, and sends it to the appropriate destination, which in this case is the State Cancer Registry. In terms of the approach, MedMorph uses an app that runs in the background in the EHR called the Backend Services App, or BSA, which means there is no workflow interruption for clinicians. It utilizes the FHIR standard and can run on any certified EHR system. In this scenario, FHIR is used for interactions with the EHR, such as notifications to and queries from Cerner Millennium, as well as sending information to other entities like the State Cancer Registry. The Knowledge Artifact Repository includes trigger codes, value sets, rules, and other artifacts needed for the BSA to know how to apply a particular use case. Common workflows across multiple use cases include provisioning, notification, data collection, report submission, and response or acknowledgement. We'll also note that the BSA has shared technology base with the electronic case reporting ECR's Now app. A little bit more about how MedMorph works. There is a reference architecture that's designed to handle needs across a variety of use cases, and this is described in the reference architecture implementation guide that's been validated and approved at HL7. Content implementation guides are then used for specific use cases. They begin with referencing the reference architecture implementation guide and then reusing existing profiles where possible, such as US Core or occupational data for health. The content implementation guides for public health use cases have been validated at HL7 for cancer reporting and healthcare surveys, with approval pending. Existing content implementation guides can also use the reference architecture. So for example, for chronic hepatitis C surveillance, we can use the electronic case reporting implementation guide for the content and the reference architecture for data exchange. There's also a research data exchange implementation guide designed to enable gathering and querying at the population level using FHIR. And that's also been validated and approved at HL7. New use cases or additional use cases follow the same pattern. So now let's take this back to Akari. Trigger codes from the Knowledge Artifact Repository are subscribed by the EHR for cancer reporting. Based on trigger codes documented in the EHR that identify an initial diagnosis of melanoma, Cerner Millennium notifies the BSA of Akari's encounter. The BSA then queries Millennium to gather encounter information for Akari, and then prepares and sends Akari's case information for delivery to one or more state cancer registries. These registries may forward the report to other authorized receivers, such as the Washington Department of Health, which works with the University of Washington for a clinical research study. And a response is also sent back from the state cancer registry to let Millennium know that Akari's case report has been received. So now I will send it over to my colleagues to describe what happens to that report when it's received by the Washington State Cancer Registry.
Hi, my name is Sandy Jones. I work with the National Program of Cancer Registries at the CDC. For purposes of this demonstration, I'm acting as the Washington State Cancer Registry. As you've seen in the demonstration, both laboratory and physician reports that capture Akari's demographics, occupation as a lifeguard, as well as her cancer diagnosis and treatment, have been sent to public health for surveillance and research. We received reports from the laboratory represented by UiPath, which provide Akari's pathology information. The pathologist entered Akari's data into the College of American Pathologists Electronic Cancer Checklists, or ECCs. Then, behind the scenes, this data was converted into a FHIR resource via the IHE structured data capture on FHIR IG. Lastly, the pathology FHIR bundle was transmitted from the laboratory information system to the EHR and the cancer registry using the HL7 FHIR Cancer Pathology Data Sharing IG. The ECCs enable pathologists to use the standard cancer data collection protocols directly within the laboratory system workflow. Cancer registries use the positive pathology reports to provide initial incidence data and alerts the registry that additional case information will be forthcoming. This is the actual bundle, the bundle that we received from UiPath, and Our system takes this data, this bundle, and parses it out and stores that data into our registry system. But this shows Akari had a shave biopsy, and here you can see parsed out, it's more human readable. We have a shave biopsy of the right shoulder. The diagnosis was a melanoma, not otherwise specified, and we have information on the staging. We also received a FHIR bundle from UiPath regarding the genetic testing that Akari received, and that she actually has a gene mutation in her tumor, BRAF. We then also parsed that data out into our registry for use. So we also received patient reports from the oncologist EHR system represented by Cerner. The dermatologist-oncologist entered Akari's case data, such as clinical diagnosis and treatment, into her EHR. Akari's melanoma diagnosis met the criteria for reportability set by the MedMorph Cancer Content IG, and thus her information was transferred from the physician EHR to public health using the underlying MedMorph framework. So this is the report parsed out that we received from Cerner, and it shows Akari's demographic information showing that she is a lifeguard, and it also shows that she was diagnosed with malignant melanoma of the shoulder, and it provides her vital information as well as medications. So Akari's cancer data was transferred automatically to the cancer registry, which makes it easier for her oncologist and physician team to meet reporting requirements for Akari and patients like her. As you can see, state cancer registries often receive data related to the same patient from multiple sources. This happened in Akari's case since pathology lab data was received separately from her clinical diagnosis and treatment. Once a year, these data are compiled, consolidated, and processed at each state cancer registry using free software provided by CDC. From there, the de-identified data are transmitted to the CDC program at the national level. Then CDC provides national level data on our U.S. cancer statistics on this website. We also provide researchers with de-identified data via the USCS public use databases and publish articles based on national data analyses. For example, public health researchers may use the data to determine the relationship between certain types of occupations, such as lifeguard, and certain types of cancers like melanoma at the population level to direct targeted prevention measures. Cancer data from Akari and patients like her from across the U.S. are captured in this tool. The CDC depends on data from state registries like Washington State for this information. Implementation of the standards and solutions presented here today will provide more complete and timely data for use. Now, I will turn it over to the Washington Department of Health team to talk about how the cancer registry data can be used for research.
Thank you. Hi, I'm Justin McReynolds from the University of Washington, representing the research team. Let's look at Akari's case report, which arrived at the Washington State Department of Health Collaborative Research Study using the standards specified by the MedMorph architecture. You'll recall that Akari was enrolled in a clinical study during an office visit. At the Washington State Department of Health, we're interested in the links between detailed occupational history and melanoma. We can learn more about melanoma and support other population health uses of the data by using the MedMorph architecture and standards-based cancer reporting through the cancer registry. Department of Health collaborates with researchers at the University of Washington to study these patients, understand their disease, and assess their response to treatment. Patients are recruited by dermatologists and oncologists, and for these patients enrolled in the study, we received an initial case report from the cancer registry. The cancer program at Department of Health collects additional data on these patients and makes those data available to our research partners at the University of Washington for analysis. We're showing you a system we use to view the received case reports in our FHIR-based research repository. The data from the case reports are stored as individual FHIR resources, accessible by other standards-based tools which can use data in this format. Those case report data have been partially de-identified to comply with our Institutional Review Board approval to use only HIPAA-defined limited data set variables. You can see here that there are 9 enrolled patients in the study for whom the Cancer Registry has sent us data. The most recent received case report is about Akari, but of course we only know her by her study ID. You can also see that we received information on her date of birth and service dates, but not name, medical record number, or other protected health information, keeping within limited data set rules. When we look at the details of the report we received for this patient, we can see we received FHIR resources for conditions, including diagnoses, for encounters, and for observations, which include her history of her occupation as a lifeguard, lab values, and other results. The MedMorph architecture supports this role for the Cancer Registry as a trusted third party, able not only to store the data in a comprehensive statewide database, but to modify and forward the report to authorized recipients. This function is very similar to what is currently implemented in electronic case reporting, or ECR, for notifiable diseases and conditions. The Cancer Registry might use the protocols and tools implemented for ECR to ensure the report has sufficient data to comply with legal requirements, to determine that a patient is participating in a research study, and then to modify the report to comply with appropriate privacy requirements and retransmit FHIR case reports to an authorized recipient. And with that, I'll return the screen back to Cerner for a summary.
We know that some skin cancer is related to occupational health exposures. This slide summarizes 18 different studies in which we can conclude that Akari's work likely gave her a 1.5 to 2 times higher risk of a different type of skin cancer. Interoperable data exchanged using MedMorph architecture and the FHIR standard will let us improve both the care of individuals, but also the entire population by allowing us to target preventative outreach. Thank you for listening.